Hello, sir. Are we good to go now? So, hello. Yes. You can start, sir. Hello, ma'am. Am I audible? Hello.
Yes, you are audible.
Good evening, ma'am. So, just prompt me when we are good to go.
I think we should wait for 2 more minutes.
Okay. So, then I will be handing over to you, right, sir?
Okay, fine.
Okay. Thank you, sir.
So very good evening to one and all present here. So today we'll be discussing about how to start IV fluids and the mere basics of the neonatal shock management. So we would wish that this should be an interactive session, and we'll try our best to involve you all, and you all are free to ask any kind of questions or any kind of doubts, whichever you feel like. And we'll try to make it with clinical based also. So now starting, I'm going to share my screen. Please enable my screen sharing. It's saying host is disabled, participant screen sharing. Ritu, please make me co-host or something. Ritu, are you able to hear me? Dr. Pratima, are you there?
Hello, good evening, sir. I am Rohit actually. Probably Pratima madam will be joining in central zone, so I will be there.
I'm not able to share my screen. Kindly upgrade me to this host or co-host so that I'm able to share my screen. Ritu, are you hearing me? Ritu Parma? Ritu. Someone can call Ritu so that she can make me co-host because I'm not able to share the screen. Okay, let it be. I think she's busy somewhere. Meanwhile, we can directly start without. Ritu, whenever you are able to hear me, just do let me know and interrupt me in between so that then I'll share the screen, right? So, dear friends, so in this around 40 minutes or so, we'll be discussing about the fluid management and the neonatal shock, right? So we all know that maintenance of fluids as well as electrolyte balance is an integral aspect of the neonatal, and we cannot imagine how we can manage the neonates without the fluids and the electrolytes. So although we know that all the clinically stable neonates who are able to take direct feed should not be given fluid, and breast milk is sufficient to maintain the fluid balance in most of the clinically stable neonates, even if they are born preterm or whatever gestation they are having, right? And the best way to feed them is through the oral route. Wherever it is not feasible, then we have to either resort to either OG feed, or if the baby is not able to feed entirely, then we have to give the parental nutrition in the form of either TPN or IV fluids. So since this group consists of mostly the first year residents, we'll be discussing more about the IV fluids in this talk. So the goal of early fluid management is to allow the normal weight loss while ensuring the physiological stability. So can anyone tell what is the normal accretion of the energy and requirement of a fetus? Anyone? So when is the time when the baby is able to accrete most of the weight? So anyone can answer. Anyone can unmute and then tell. Okay, in the third trimester, it is usually the time after the 32 weeks, the baby gains the weight exponentially, and this is the time when the baby gains maximum protein as well as fat. So therefore, it is very important for us to provide the nutrition during the last trimester. And if we are not able to provide nutrition to the babies during the last trimester, then they are at a lot of morbidities and even mortality may occur. So energy has to be provided to the baby, whatever is the reason, right? Whatever is the way. That is very, very, very important. Okay. So what is the objective of the today's talk? So the first part is we have to identify the babies which need IV fluids. So we all should remember that not all the admitted babies, they require the IV fluids. Most of the babies can be thrived well upon the oral feeds also. But as a resident, we should be able to note that yes, this baby requires IV fluid. Once we have identified that which baby needs IV fluid, we should be able to calculate the daily fluid as well as the electrolyte requirement, right? And after we have calculated the daily fluid and electrolyte which is required, we should be able to administer the IV fluid with micro drip set or the syringe pump, whichever is available. So these days, most of the medical colleges, most of the private hospitals do have a syringe pump. So micro drip set is going out of the fashion, but at PHC level, CHC level, and district hospitals where the syringe pumps are not available, we should be able to administer the fluids by using the pediatric drip set also.
Hello, sir. Sorry to interrupt you. Kindly check with the screen sharing, sir.
Okay, you're making me that.
Yes, sir.
Thank you.
Welcome, sir. It's appearing.
Yeah, is it visible now?
Yes, sir. Just need to make it full screen, sir.
Yeah, I'll do. Fine. Okay.
Thank you,
Is
sir.
the screen visible? Thanks. Okay. So, so we have to identify the babies who need the IV fluid. Once we identified those babies, we have to calculate the daily fluid requirement. And once we have calculated, we should be able to administer the IV fluid with the pediatric drip set, or as I've already told, with the syringe pump. The babies who are having the IV fluid should also be monitored, and they should be seen for many things which we'll be discussing about them. And when we start the enteral feeds, we should be able to adjust the IV fluids also as per the feeds are being built. So what are the indications of giving IV fluids? Anyone? Write in chat box. So what are the indications of starting IV fluids? Please write in the chat box. So which baby should be given IV fluids? Few answers. Come on. Very good. So Ruby has written critically sick child. Very correct, Ruby. So all critically sick children should be given IV fluids. So any baby who is on iron drops, substitution correctly. Feed intolerance, yes. Dehydration, shock, refusal to feed, okay. Right. So neonatal shock, very nice. So any sick baby should be given IV fluids, right? So babies who are extremely premature should also be given IV fluids, right? So not only the critically sick, we do not have to wait till the baby becomes critical. We have to catch the baby before that, and we have to decide that this baby has got poor gut perfusion. So whenever we anticipate that gut perfusion is poor, we have to start the IV fluids, right? So let me give an example. So any sick baby who is not expected to tolerate the enteral feed should be started on IV fluids, right? In this, the commonest example is the baby having respiratory distress. Even if it is a term baby, if the baby is having severe respiratory distress, we should not give. Any baby who has got hypotension or neonatal shock should not be given. Any baby who has got severe perinatal asphyxia, definitely. Even moderate asphyxia also we start with IV fluids. And any GI abnormality because of any congenital or NEC, these are terminal things. But even before that, if the baby has got altered aspirate or mild abdominal distension and the abdomen is tense, or any kind of thing where we suspect that the baby will not be able to tolerate the oral feed, we should start IV fluid in those babies, right? So it is important that we should be able to start. Any neonate, even on day one, if is less than 30 weeks, should also be given IV fluids to start with. And meanwhile, if the baby is stable, we can give minimal enteral nutrition in addition to the IV fluids also. And that fluid has to be subtracted from that, right? So which baby should be given is an important one, right? Okay. So choice of fluid, that is very important. So in first 2 days of life, we all give electrolyte free fluids. So it is important to note that why do we give electrolyte free fluid? We all must have noticed that we give 10% dextrose on day one of life, right? So the extravascular compartment of the neonate is already full. The babies already have extra of the fluid. So if we provide the electrolyte, it will be detrimental for the baby. Therefore, during the first 2 days of life, we should not add sodium. Rather, as a dictum, we see that when the baby has started passing adequate urine and when the baby has started losing weight, then only we should add sodium and electrolyte. So therefore, in the starting 2 days of life, we should give electrolyte free fluid. 10% dextrose is the most common fluid of choice one, right? So the second point I have already told, sodium supplementation is not required. And after 48 hours, as I've already told, once the diuresis has started, the baby has started passing adequate amount of urine, that is usually 6 to 8 times a day, then we have to add electrolytes in the fluid. Before that, we should not add, right? So the choice of fluid is 10% dextrose. Here, someone may argue that in the extreme premature babies, why not use 5% dextrose? So when we were doing our MD, So we used to routinely give 5% dextrose to the babies who were weighing around 700 or 800 grams at the time of birth. But nowadays, with the advent of very good glucose monitoring machines, so we do not need to start uniformly 5% dextrose in all the babies who are ELBW. Rather, we start with 10% dextrose, and if the sugars are high, then only we switch to 5% dextrose. Otherwise, 10% dextrose is used commonly and standardly, right? So it is important. 10% dextrose is the standard treatment. Okay. Now, once we have decided that we are supposed to give IV fluid, how should we give the IV? So first is there are two options of administering the IV fluid. The first is we can use a drip set. This is pediatric drip set, which is commonly seen. Earlier times, it was very commonly used. Now also it is used in pediatric population for giving IV antibiotics. But these days, government is providing syringe pump to even CHCs, so there are less chances. But suppose if we have a limited supply of syringe pump, or there is some equipment malfunction, then we have to shift back to the pediatric drip set. So we should know how to use the pediatric drip set. Otherwise, syringe pumps are used. One. Second thing, we should remember that 1 ml of pediatric drip set is equivalent to 60 microdrops. So it is very important to note that the 1 ml is 60 microdrops. So therefore, whatever fluid we want to give, we have to calculate the drips accordingly. Okay, another question to you. So if you want to give 20 ml per hour, right? So how many drops should we set in the micro drip set, in the pediatric drip set? Please write in chat box. My question is, you want to give 20 ml per hour. So what should be the rate of fluid in pediatric drip set? Okay, people are writing 20, Ruby and Dr. Pajuria. But any other option other than 20? Okay. Anyone else? Okay, 20 is the correct answer. So you all should remember that whatever rate we want to set, right? Whatever rate we want to set per hour, that much drops are set in pediatric drip set. So if we want 20 ml per hour, we have to set the rate at 20 drops per minute, right? In this slide, I have shown that if we need 6 ml per hour, we should provide 6 drops per minute. So just remember, whatever ml per hour we want to give, just set that rate there, right? So we have to calculate the drop rate, and we have to see there in 1 minute how many drops are going, right? It is usually in the pediatric drip set possible to decrease the drop rate to around 4 to 5, and that is exactly which is commonly required in the very small babies, because it is very unlikely that we'll be giving more than 4 to 5 ml per hour, right? So, but still, there are chances that the tubing gets kinked, or there is some issues in the pediatric drip set because it is not an electronic device. It is more prudent that it could be blocked also. So syringe pump is a more reliable way, and we all must have seen in the syringe pump what is there with electronic device. We attach a PMO line or pressure monitoring line. It is connected to a syringe, and with the continuous pressure, it is able to deliver a set amount of volume to the baby, right? So, but the only disadvantage with the syringe pump is it will keep on flushing the IV cannulas, and even if it is blocked, unless until there is occlusion alarm, it will keep on delivering and there will be swelling in that. Whereas in pediatric drip set, usually it gets occluded very commonly. So we have to take care in both the syringe pump as well as pediatric drip set in that the fluid is being not being extravasated, right? So this is the common method, which is, you must have seen a video which was posted in the group earlier, that how to attach the fluid to the syringe pump, right? So now we'll be discussing about that only in next few slides. So during the administration of IV fluid, so you should remember that the neonates, the most common cause of mortality is sepsis, which is preventable. There could be other causes like birth asphyxia, preterm. So this is our like prematurity is less preventable. Birth asphyxia, once it has occurred, then the sequelae are there. We can prevent the sequelae, but we cannot prevent the birth asphyxia. But this neonatal sepsis is one which is easily preventable, especially the late onset one. So the only thing which we can do is to prevent sepsis by ensuring very strict hand hygiene and aseptic precautions in whatever things we do to the neonates. So we have to use totally aseptic precautions while handling the baby and wherever possible. So during the administration of the IV fluids, since the fluids are directly going in the vascular compartment of the baby, so if any contamination occurs in the vascular compartment, in the fluid, or during the administration of the fluid, the infection will directly go into the bloodstream. So there are chances that the baby will become sick. So administration of IV fluids is very, very important, right? Any breach in the sepsis during that period will lead to very detrimental consequences. So aseptic precautions are required, and we have to use sterile gloves while filling the syringe pump or micro drip set, right? So we usually calculate the fluid requirement for 24 hours. We should not calculate for 8 hours. The full day fluid requirement first should be calculated. Then we have to ensure that if we are giving through pediatric drip set, we should not fill fluid more than 8 hours of it. And morning, evening, night, every shift it should be refilled, right? So this pediatric drip set 8 hour maximum. And in the syringe pump, we should give 50 ml. So 50 ml, and then how much time it takes, that depends upon that, right? So it is also important to maintain strict input and output chart and review it every 8 hours. And there is a very good method of this. So suppose you have filled the syringe up to 50 ml and the rate is 6 ml per hour, right? So after 4 hours, is there a method by which you can tell that yes, the baby has received that much amount of fluid? Anyone? So is there a method of counter checking that the baby has received whatever fluid was intended to reach? Anyone can unmute also, right? So my question again is, if you had charted that 6 ml per hour is to be given, one, and after 3 hours, you want to ensure that, yes, the baby has received this much fluid only. How will you confirm? Okay. Okay. So whenever we give the fluid in a syringe or a syringe pump, there is a column usually in the monitoring sheet that mentions that how many fluid is remaining in the syringe, right? So if we intend to give 6 ml per hour and we have filled 50 ml syringe initially, that after 1 hour we label that now there is 44 ml. After 2 hours there is 38 ml. After 3 hours there is 32 ml. So that is an indirect evidence. The sister on duty should definitely check that whatever fluid was supposed to go has gone or not. So it is visible by the markings on the bottom, on the syringe, right? So we calculate the fluid requirement for 24 hours. We maintain the strict input output chart and include the volume of medications also and IV flush also in the total fluid calculation. So this is the common error which we do. So suppose we are giving some medicine which is to be given 10 ml diluent and we have to give 3 times a day. So 30 ml fluid it will become. So it is very, very important to calculate that volume also, and we should be able to deduct that from the total volume, right? Not only that, we should secure the IV cannula properly with a skin-friendly adhesive tape, taking care that all the skin barriers, that hygiene is maintained, the skin is not breached. And it is not a uniform practice to use the splint unless until we have put the cannula on a joint. If we are putting the cannula on a joint, then we may need to splint it. But as a routine, it is not recommended to use splint in all the neonates and all the cannula sites, right? So, we have to remember that before infusing the IV fluid, we have to check the expiry date of the fluid. It has commonly been seen in the hospitals which are being provided the government medicine. There is bulk of medicine, and at times we can get the stock which comes to us an year ago, and since we get stock in bulk, there are chances that we might miss the expiry date. So it is very, very important to see the bottle and check the expiry date of the fluid before giving it of the fluid. One. Second, there is chance that the seal of the infusion bottle is broken. So there are chances that the infection may creep in. So it is also to be checked. We should also see that the fluid is clear and free from any visible particles. At times, we have seen that the fungus is growing in the IV fluid. There are particulate matters in the IV fluid. So before opening the bottle or before attaching the fluid to the baby, we should visually inspect the bottle of the IV fluid for the clearness, for the expiry date, and for the intactness of the parenthelia of the bottle. So these days, the government of India is providing free medicines to all the neonates who are admitted in SNCE. So as a policy, we should change all the assembly within 24 hours. So after 24 hours, the PMO line, the syringe, as well as the fluid and the connecting line, it should be changed ideally. So if there is scarcity of the medicine or if there are logistic issues, still we should change it every 72 hours. So it is very important. Even if the fluid is there, extra fluid is there, we should not use that fluid for the baby in the next day or whenever the time we have decided. One. Second, we should not cross use the fluid from one baby to the another. So we should try to use a closed loop mechanism for one baby. So one baby, one bottle, one set, right? So we should not practice that from single IV fluid bottle, we are filling the fluid for all the babies, because see, what is the cost of the fluid? So most of the time, if we are working in government hospitals, it is provided to us free of cost. Even if the baby is in some private hospital or we are doing some private practice, the cost of the fluid and the assembly would not be more than 300 to 400 rupees. So if we continue using this at the expense of the sepsis that we are giving to the baby, it is not going to be cost effective. Even a single episode of sepsis prevented will be much more beneficial as compared to the cost which we are providing. And definitely in government hospital, we should try to discard the fluid after what the logistically whatever time is feasible. If there is enough number of sisters, if there are logistically ample supplies available, we should definitely change this within 24 hours. And these are the guidelines of FBMC also, right? Okay. So now coming to how much fluid we should give. So there are two school of thoughts. The volume of the fluid which is to be given to the baby depends upon the birth weight and the postnatal age. So I've written gestational age in brackets because the fluid requirement of preterm baby is generally lesser as compared to the term baby, generally more as compared to the term babies because of higher insensible levels. But for uniformity and for all practical purposes, we do not take into account the gestational age. We just see the birth weight of the baby. So as a rule of thumb, we just categorize the babies into two parts. If the baby is more than 1.5 kg or less than 1.5 kg. So if the baby is more than 1.5 kg, we start IV fluid with 60 ml per kg. And as per FBNC guidelines, we increase it in the increments of 15 ml per kg per day. So 60, 75, 90, 105, 20. In 7 days, it is 150. So if the weight is less than 1500 grams, we get bit higher of fluid volume on day one. We give 20 ml per kg extra, right? So instead of 60, we give 80, then again 15 ml per kg, so 150. So various institutes also use 20 ml per kg of increment. So it is perfectly fine. But as per FBNC guidelines, in this course, we'll be discussing about 15 ml per kg. But it depends upon institute to institute. So we can increase 20 ml per kg also, right? So this ml per kg per day is to be very diligently calculated. And as I already told, that we have to decrease the amount of medicine and the boluses which have been given to the baby, right? So how much energy expenditure is there in a low birth weight unit? So totally what we require is, we require 90 to 120 calories per kg per day. It is very important to note, right? So whatever fluid we want to give, suppose we are giving the breastfeed to the baby. So let me tell about breastfeeding. So 100 ml of milk contains around 67 calories, right? So the ideal requirement of the baby is between 90 to 120 calories. So if you want to give 90 to 120 calories, we have to multiply it by 1.3 times, and it gives the amount of volume of the milk that is provided, right? So that is the rationale why we use this much amount of volume of the fluid, maximum volume that we need, right? So if we see the breakup of this, then the energy expended by a baby is 40 to 60 calories per kg per day. So 15 calories per kg per day are utilized for the synthesis of various anabolic products in the body. So 20 to 30 calories per kg per day are used for storage, and 15 is used for excretion. So this is gone. Whatever we do, it has to be provided. And total is 90 to 120. So it means that even if we want to restrict the fluid, we have to provide minimum of 40 to 60 calories per kg per day to the baby, so that the expanding requirement of the baby is met, right? So this is a minimum amount of fluid, whatever is the cause. Suppose the baby is in the renal failure, we have to restrict the fluid. Still, we have to provide this much of the energy to the baby, and consequently this much energy, this much fluid to the baby, right? So it is important to note that 90 to 120 calories per kg per day are minimally required so that the baby gains weight adequately, right? Now, tell me this. This is a common scenario for all. So if we want to calculate IV fluids for a 4-day-old neonate, the birth weight was 1.2 kg. What is the total fluid requirement on day 4 of life? Please tell. So day 4 of life, 1.2 kg weight. What is the total fluid requirement? Come on. You can speak also. So what are the things that we should note? Which two things are important in this? The first thing is, as I've already told, that is the weight of the baby. So this fits into which category? VLBW or LBW? Okay, Anmol has written 125. Good. Okay. So two things are important in this. The first thing is the day of the baby. And the second thing is weight of the baby, right? So 1.2 kg baby, that means our baby fits into the birth weight of less than 1.5 kg. So if the birth weight is less than 1.5 kg, on day 1 of life we give 80 ml per kg. So 15 we increase, and day 15 we increase, right? Okay. So let's see. So this is the thing that we should remember as per table which we have already shown. So this baby requires 125 ml per kg per day. So many people have written 125 ml per kg per day. So if we multiply 125 into 1.2, it comes out to be 150 ml per day, right? So 150 ml per day given over a period of 24 hours, we divide it by 24, it comes out to be 6.2 ml per hour, right? So if I just show you the table again, right? So, so this was the table, right? So 80 on day 1, and day 4 it is 125. Okay. So you have written correctly that 125. The only thing is that you had mentioned 125 ml total. It should be 125 ml per kg. So, right. So 150 ml, 150 ml is fine, right? So 150 ml and 6.2 ml per hour for this, right? So whenever we want to fill, if we want to fill in the syringe pump, we fill 50 ml, right? So since we have to give for 8 hours, it is fine. So how do we order? Day 4 of life, so we have to write as ISO P 150 ml in 24 hours or 6.2 ml per hour if we are giving with a syringe pump. So if we are giving with a micro drip set, it gives us a problem because we are not able to calculate 6.2. So there we have got two options. We can write 6 ml per hour for first 12 hours and then 7 ml accordingly. We have to make a balance between the two. right? So this is how we calculate. So two things were important. One was the age of the baby, and second was the initial birth weight of the baby, right? Okay. So next important thing is how do we monitor the baby on IV fluid, right? So what all things, kindly tell again, what are the things that we should monitor when the baby is on IV fluids? Mention in the chat box, please. When the baby is on IV fluids, what all things we should monitor? There are many things definitely. So dextrose, Neha is saying we give ISO P. We have to give electrolyte fluid, right? Not uh, electrolyte free fluid in the first 48 hours only, right? So urine output is very good. So Amber is written urine output. Pranjal is written heart rate. Okay, heart rate. Pranjal, heart rate is fine. And intake output, cannula site, RBS, extravasation, very good, very comprehensively written. Good. So very correctly written. So these are the things that are very important, right? So we have to inspect the infusion site every hourly, right? So in the monitoring sheet, the sister has to see the infusion site. So every hourly it has to be written. We have to look for redness and swelling around the insertion site, which indicates that the cannula has gone out. And definitely we have to pick it up before the visible swelling occurs. The first sign is redness. So whenever there is redness, we should be able to pick it up. And for this, we have to use the semi-permeable transparent adhesive on the cannula site. So it is definitely very important to put the transparent adhesive on the cannula at the tip, right? So even if you are using um, the micropore or dynaplast, which do not give us a direct access to the site, then we should leave the tip of the cannula visible to our eyes. So the tip of the cannula should never be covered, even whatever type of occlusive dressing we are using. So that because the issues will come at tip, not at the where we insert the cannula, right? So it is very important to use that kind of dressing, right? So this I have already told. We have to check the volume of the fluid which is infused by minusing it from the total fluid, right? And then once every nursing shift, it should be the blood glucose should be monitored as already told in chat box. 6 hourly, we should do the RBS monitoring, right? If the glucose is less than 45 or if it is the baby is on GIR, then whatever we are targeting, then we should also treat for low blood glucose and change the fluid accordingly. If it is more than 150 milligram on two readings, 1 hour apart, then we have to decrease the GIR, and then again we have to check the blood glucose after half an hour. And if the baby is on 10% dextrose, we can also decrease the baby to 5% dextrose if it is indicated, right? So these are the things that we should see. So we also weigh the baby daily using the appropriate weighing scale. Urine output, yes, we should monitor, but we should not put a catheter routinely. The nappy weight is fine, right? A number of times of passage of urine is fine. So weighing of wet nappies is fine. Then signs of overhydration is also important. So if there is edema, if there is excessive weight gain, if the baby has started having respiratory distress, then we should also be cautious. So if the baby's weight, this is very important. If the initial baby's weight was 1.5 kg and after 5 days the baby's weight is 1.6 kg, we should calculate the fluid requirement as per the maximum weight. But if the weight is less than the birth weight, then we should calculate birth weight only. It is very commonly seen that the babies lose weight during the first few days of postnatal life. So if the baby has lost weight, we should give the fluid according to the weight which is more. So either the birth weight or the maximum weight is given. Once the birth weight is regained and the baby has started gaining weight, then we give the fluid according to the more weight which will be, right? So if the daily weight gain which is permissible is more than 5%, then we have to increase the total volume by 10 ml per kg. So we do it for 1 day and then we reassess. If there is no weight loss or there is weight gain in the first 3 days of life, then we stop the daily increment because we expect that during the first 2 to 3 days of life, the baby will start the diuresis and the weight will be less. This is also the reason why we do not provide extra fluid during the first day. And if whatever colostrum comes and howsoever small amount of breastfeeding comes, we prefer that only. Because nature has provided the human body so that even if the fluid milk in output is less, it is enough to sustain the baby, right? So once the baby started losing weight, then only we add the electrolyte free fluid. So if there is no weight loss, or there is weight gain, then we do not give the daily increment, right? But if there is excessive weight gain, that means the baby is not able to handle the fluid, then we have to decrease the fluid intake by 10 to 20 ml per kg per day. So it depends upon the weight also. So if there is oliguria as well as weight loss, so there are two things. One, the urine output is less plus weight loss is less. That means we have to increase the volume. Then we give 10 to 20 ml per kg, extra feed is to be given or extra fluid is to be given. But if there is a oliguria plus weight gain is there, so that means the baby is not able to handle the extra fluid. So as compared to the previous one, here we have to decrease the fluid volume and we also have to evaluate the renal function because two things are there. One, the baby is not passing urine and at the other side, the baby is gaining weight also. So both things are important, right? So if there is renal compromise, then what do we do? As I told in the energy expanded table, then we have to replace the insensible losses, right? As electrolyte fluid, free fluid only. We don't give sodium, potassium, only dextrose fluids are given. And whatever urine output the baby is providing, the baby is excreting, that is to be replaced as N/2 saline, right? So whenever we are restricting the fluid, we should always ensure that the GIR is not less than 4 because that is the basic requirement. If it is less than 4, then there are chances that the baby will develop hypoglycemia, right? So if the fluid requirement is less, then we have to concentrate the GIR. So we have to increase the GIR, okay? So this is also important. So if it is intestinal obstruction, then we have to replace the gastric aspirate by half normal saline. If it is bilious aspirate, then we have to give by RL on volume basis every 8 hourly. So how it is done? Suppose we calculate that the bilious aspirate is 50 ml in last 8 hours. So whatever fluid we are going to give in next 8 hours, we add 50 ml extra in that 8 hours, right? So it is important. So whatever fluid is given, it is to be added to that over the next 6 to 8 hours, whatever we have calculated. So serial recording of weight is very, very important. So we have to see that if there is dehydration, it is corrected slowly over 24 hours. And the fluid used for deficit correction is N/2 saline, right? So if it is to be corrected, half of the deficit is corrected over 8 hours and remaining half over next 16 hours. So this is in addition to maintenance fluid. So if there is severe dehydration, we can also give as plan C for IMNCL, right? So a simple, practical, pragmatic approach is if there is severe dehydration, we can give 1.5 times DNS/2, right? If there is moderate dehydration, we can give 1.25 times the fluid, which is the NS/2. So half normal saline, we can increase it, and alternatively, we can give as per IMNCI also, right? So once the analysis is established, we should add potassium in the fluid. 1 ml, we all know that 1 ml of IV KCl contains 2 milliequivalent of fluid. So how to adjust the IV fluids with enteral feed? So as soon as possible, start the enteral feed. Right? This is very important. So minimal enteral nutrition has to be provided as soon as possible, as soon as the baby is stable. So we have to increase the feeds also. If there is no distension, if the baby is not able to take directly breastfeed, then we should give by EBM using the cup or the paladi. And even if that is not possible, we have to give by OG feed. If the baby is tolerating tube feeds, then increase the volume by 20 to 40 ml per kg per day. And weight by weight, volume by volume replacement we do. So we keep on decreasing the fluids and we keep on increasing the total feeds. We gradually increase and then we decrease the IV fluids gradually. Then what do? Next is we chart the total fluid requirement per day as per our table, and then we subtract the daily volume of the fluid feed and give the remaining as the IV fluid only, right? So that is important to minus the feed also, because we give total fluid plus feed, which is to be given, has to be calculated. So as soon as the baby is receiving 100 ml per kg per day, then we should stop the IV fluids, because there are a lot of disadvantages of giving IV fluids. And it is expected that once the baby has reached 100 ml per kg, in next 2 days, the baby is expected to reach full feed. So we can, if we are going to be liberal, we can decrease, we can even stop the IV fluids as soon as this number is met, right? Okay. So let me give an example. The same baby. So 1.2 kg baby, gestation 31 weeks, hemodynamically stable. The baby is on CPAP by nasal prong. Simple plain CPAP, stable. What are the fluid orders? Day 1 of life. Anyone? So 1.2 kg, day 1 of life, fluid orders, baby is absolutely stable. Okay. Would you start feed, or would you start fluid, or would you give both? Anyone? So would you start feed, fluid, or both? Okay. Since the baby is absolutely stable, we should go for both, right? It is very important. So we have to give both. And if the baby, let's say, he is not able to be fed absolutely with the breast milk, we can give minimal enteral nutrition definitely to the baby. So total fluid requirement is on day 1 of life 80 ml per kg. It is 96 ml per day. So if we give 30 ml per kg of minimal enteral nutrition, that comes out to be 36 ml. So we have to deduct this 36 ml from 96 ml. It comes out to 60 ml. So this 60 ml per day is to be given over 24 hours, right? So the carry home message from this is, whatever feed we are giving is not extra. We have to deduct that feed from the total fluid requirement. Okay. So 60 ml is to be given over 24 hours of fluid and 36 ml of feed, right? It is important. So now this baby is on day 2. So now the total fluid requirement is 95. So we have to give 114 ml. So now we have increased the feed to 60 ml per kg, suppose. So this 72 ml has to be deducted. So now it comes out to be 42 ml. So 10% extra 42 ml is to be given at 1.8 ml per hour by infusion pumps, which are having the single digit decimal point, or these days there are the infusion pumps we can feed in 2 points also, 1.75. If we are giving burette, pediatric drip set, we can give 2 ml per 2 ml per minute, right? 2 drops per minute, right? Okay. So day 3, again, we can stop IV fluids as we expect that the total feed is 100 ml per kg, right? If the baby is absolutely stable, day 3 will remove the IV fluids. So this is how we do in our unit. We do not give extra IV fluids whenever possible, and you also must be following the same practice. So as soon as possible, remove cannula. As soon as possible, stop IV antibiotics. So these two things will go a long way in decreasing the mortality as well as morbidity, right? So day 4, again, no IV fluids, right? This is you all must be doing. Okay, another baby. So 1.2 kg is the same scenario. Hemodynamically stable, day 1 fluid order. This is again the same. Okay. So what is the difference in this? So once we have decided in a bigger baby, what do we do, right? So we have to replace if the baby is absolutely stable, and we have decided that we have to give total feeds only, no IV fluids. If this is the case, then we don't have to give IV fluids at all, and we can directly give the feeds, total feeds also, right? So key messages in regarding the IV fluids. 1, till the baby starts diuresis, till the baby starts losing weight, it could be more than 48 hours, right? We have to give electrolyte-free fluids. It is most commonly 10% H2. 1. Second, after 48 hours of life, once the diuresis sets in, and once the baby has started losing weight, then we shift to electrolyte fluid. The common fluid is isolate P, right? So 5% extra containing sodium potassium as maintenance fluid. Depending upon the weight of the baby, daily 15 ml per kg increment we have to give. We should not give fluid by IV set. So since the babies are small, we need absolute small amount of fluid. So either syringe pump or pediatric drip set, right? once we are starting IV fluids, the baby has to be monitored. So two important things are weight monitoring and urine output. These two are very, very important. Biochemical investigation, they are also done, but RBS, weight and urine output, these things are very important. Next is we have to start the feeding as soon as possible. And as soon as possible, the enteral feeds are to be given and they should be initiated in all stable units, right? So that was all about IV fluids. So any question up to now? Otherwise, in next, we start on the neonatal shock, right? So I'll just stop for a second. So anyone, any question till now? Okay, anything you want to ask for this fluid, you can write in chat box. Okay. Okay. So we'll now shift to neonatal shock, right? So what is shock? So it is also a very common thing which is seen in our NICUs, SNCUs, right? So what is shock? Shock is defined as a clinical state, poor perfusion of the baby in which baby's demands of oxygen and nutrients are not met. Having said that, simply saying the perfusion of the baby is poor. Once the perfusion is poor, oxygen will not be there, right? So once the shock sets in, there is tissue hypoxia, there is metabolic acidosis, and irreversible tissue damage. So hypotension is a late manifestation. So shock and hypotension is important to note that shock and hypotension are not synonymous. The baby might be in shock, but not hypotensive. So once the BP starts falling, then we tell as hypotension, right? So a BP that is lower than the expected reference range, like we all see Zubro's chart, so it is measured by NIBP. So that is hypotension, but there are other features of shock, right? We'll be discussing about that. So the first and the foremost feature of the shock is unexplained tachycardia. So the earliest sign of shock is unexplained tachycardia. So it is telling that this slide is, we have to be very, very vigilant once the heart rate starts rising more than 160. But it is an increase in heart rate from the baseline, which is more important. Suppose the baseline heart rate of the baby is 170, 180. Then if it is increasing from the baseline, then we have to be vigilant, right? So unexplained tachycardia may be an early sign of shock. It can again also increase if the baby is in pain, stress, or hyperthermic, or on caffeine. A very common thing, the baby is on caffeine, right? So it is definitely very important. So if these things are ruled out and there is unexplained tachycardia, then we should always think that our baby might be developing shock, right? Okay. Second important thing which we should routinely see in our babies, CFT or capillary refill or capillary filling time. So we put our finger on the sternum, right? So our sternum, we press it for 3 to 5 seconds, and then we count from 1000, 1000, 2000, 3000, 4000, 5. So we have to set our own pace, and we know when the 5 seconds are over. Then we remove, we keep it like this, 1000, 1000, 2000, 3, 5. And so we remove it. We see how rapidly the perfusion returns, right? So how this blanched area refills, we all know this. How this blanched area refills, the normal CFT is less than 3 seconds. If it is more than 3 seconds, that means perfusion is poor. It indicates the circulation is poor and something has to be done. But we also have to see that our baby is not hypothermic. If the baby is hypothermic, then it could be fallacious and we have to correct the temperature disturbances first, right? Okay. So other features of pulse shock. So once again, I'm telling that BP falls in the end. So if there are poor pulses in neonates, we see the brachial pulse, not the radial pulse, right? So if there is pallor, the skin is mottling, if there are cool extremities, if oliguria is there, if baby is developing lethargy, and lastly, if the baby is hypotensive. So these are the other features of shock. But two things are again important. One is increasing heart rate and second is CRT. So these two things are very, very important. So any baby, just see the heart rate next day or whenever you want to see, just a pattern. If daily heart rate was 140, 140, 140 and suddenly it has started 170, तो आपके कान खड़े हो जाने चाहिए, right? So these things आपको pick करना पड़ता है pattern कि heart rate उसका increase करने लग गया, right? This is very important. So coming to management, so I'll just give a brief overview of this. So it takes full day to teach about the shock. I'll just touch as per FBNC guidelines. So the outcome of the shock depends how we are able to diagnose it and how sooner we are starting the management. If we miss the shock or if we pick the shock once BP is less, we have already missed the bus. तो अगर किसी बच्चे का बीपी फॉल होने पे हम पिक कर रहे हैं, फिर बहुत लेट हो चुका होता है, फिर टाइम बहुत लग जाता है उसको पिक करने में. तो आपके लिए जैसे ही हार्ट रेट उसका इंक्रीज करने लगे, आपके काम definitely you should be vigilant, right? So once the shock sets in, we have to maintain the temperature away, breathing circulation. So if the baby is hypothermic, we have to maintain the temperature. If the baby is hypoxic, so any baby who is in shock, we should provide oxygen because perfusion is already less. So whatever means we want to give, if the baby is not on any support, give prong, if it is CPAP or whatever is the requirement of the baby, but oxygen has to be given to maintain the saturation of the baby in the target range. If the baby is having hypoglycemia, we have to maintain the normal sugar, right? So specific perfusion is important. So specific, we all know that perfusion तो हमें improve करना ही करना है. कैसे improve करना है वो हमें देखना है. So if the baby is having fluid responsive shock, so the first thing is we always give a 10 ml per kg of normal saline over 20 to 30 minutes. So this is very important, 10 ml per kg over 20 to 30 minutes. So if the baby is 2 kg, we give 20 ml. We tell our sister that give over 20 minutes. So if you want to set the rate of 20 minutes, then you have to calculate how much fluid will be going in 1 hour. Suppose I'll give you a hypothetical example. So if the baby is 2 kg, you give 10 ml per kg, so we have to give 20 ml of the fluid. This 20 ml has to be given over 20 minutes, right? So that means अगर 60 मिनट में देना होता तो कितने पे रेट सेट करते, फिर आप 60 ml पर आवर पे रेट सेट करते. तो आपको बताना पड़ेगा सिस्टम को कि स्टार्ट एट 60 ml per hour so that this 20 ml goes in 20 minutes. So we commonly do the mistake, हम 20 ml की syringe भर के दे देते हैं और हम 20 ml per hour पे start कर देते हैं, but then it will take 1 hour. So this rate is very important to give, right? So rate is important. So how do we assess? Once we start fluid, the first thing that will come up is heart rate. So the heart rate which was increased, so it will decrease. So the first outcome or the end point is the heart rate should start falling. So baseline heart rate say now if it is decreasing by 10 beats per minute, that means हमारा end point achieve हो गया. So the first is heart rate decrease and the decrease in CRT, right? So these two things are important. If there is still tachycardia, if the CRT is still prolonged and liver is not enlarged, then we have to give a repeat bolus, right? If the pulse volume is now better and if there is better urine output in next 4 to 6 hours, then it is a good sign. That means our baby is responding. So the first thing is increase in heart rate. The second is increase in heart rate we can directly see on monitor. The CRT, we have to touch the baby, but this is also very commonly visible, very commonly elicitable. So these two things are very rapidly checked, right? And then increase in urine output over next 4 to 6 hours. And pulse also we can feel. And visibly we can also see the mottling of the skin, but it takes bit longer time, right? Okay. So suppose the baby does not improve on fluid, then what is the next line of management? So if the baby does not improve on fluid, that means we label as fluid resistant shock, and now we have to give the vasopressor. So as per FBNC guidelines, I'll not go into much details. So as per these guidelines, we start with dopamine, right? So if the baby has got 2 boluses and the baby has not improved, then we start vasopressor. So supportive care should be continued. Underlying causes of shock should always be assessed and they should be looked after. And the vasopressor should be started, right? So most common vasopressor which we give is dopamine. It is the first line agent. So it is a very good drug. Usually we start at 10 microgram per kg per minute. And if there is no improvement, we can increase by 5 microgram every half an hour to maximum of 20 microgram. So we start with dopamine. If you have to remember one thing as of now, and if you are going and is going to instruct your staff to take care of it, fluid bolus followed by dopamine. This is the standard, right? So I'm just telling a crude method as per the FBNC guidelines. No doubt there are newer guidelines which tell that functional echocardiography should be there. There are controversies regarding the first line whether dopamine should be used or ADR should be used, whether the steroid should be used earlier. But as per these guidelines, you should remember that dopamine is the first line of management, right? So how to give dopamine? This is again important. We all should remember that 1 ml dopamine contains 40 milligrams. 1 ml dobutamine contains 50 milligrams. So dopamine contains 40 milligrams. If the baby is 2.5 kg and we want to start at 10 microgram per kg per minute, we calculate over full day requirement. And once we calculate that full day requirement, whatever it is of requirement of the dopamine, an easiest method is that much dopamine is given is added to 24 ml normal saline. Total is made. Suppose we have to add 1 ml of dopamine. Suppose 40 milligram dopamine is to be given over 1 day, right? Then what we do, 1 ml contains 40 milligram. So we take 23 ml of normal saline, right? And we add 1 ml of dopamine. And then we give 1 ml per hour. So that gives the dopamine for 1 day. So whatever is the calculation, so that amount is added to make the total fluid as 24 ml. A simplest method is 28.8 milligram of dopamine per kg is to be given if we want to give 20 microgram per kg per minute. So if we want to give 10, we start at 0.5 ml per hour. It is as simple as that. 28.8 micro mg per kg of dopamine over 24 hours, right? और भी अगर रफ लेना है तो 30, बिकॉज आजकल कैलकुलेटर्स हैं तो 28.8 को कैलकुलेट कर सकते हैं. अदरवाइज जब कैलकुलेटर जब मोबाइल्स नहीं होते थे, we used to give 30 mg per kg, but 28.8 is the exact figure, and the same is true for dobutamine also, right? So this is what we use. So how do we have to give this? I have already told. If with the syringe pump we used to add 4 ml, but if the syringe pump is not available, then we add this to the 8 hourly maintenance fluid and we run at the rate of whatever is the fluid of the maintenance, right? So once we start the dopamine or the dobutamine, we assess the heart rate, the CRT, as well as the pulse volume. If we have got the facilities of NIBP, then we should also check the NIBP. But the gold standard is arterial BP measurement, right? So majority of us do not have arterial BP modules. So we have to rely upon non-invasive BP modules only. So once the shock has set in, it is very important to know that we reassess the baby within 20 minutes. So as soon as 20 minutes are over, we should be able to assess that heart rate has improved or not, the CRT has improved or not, and if there is inappropriate response, we increase by 5. So we do not have to wait for 2 hours. So जैसे ही हमने फ्लूइड दिया फर्स्ट 20 to 30 minutes वेट किया, सेकंड दिया, उसके बाद डोपामिन स्टार्ट कर दिया, एंड देन 20 to 30 minutes we again increase. तो जल्दी जल्दी करना पड़ेगा. तो 2 घंटे में तो बहुत कुछ हो जाता है. It is very important to know that we cannot afford to miss the bus in the first hour, right? If despite dopamine of 20 microgram, then we use dobutamine, right? So similar doses as per dopamine. So first line dopamine, second dose dobutamine. But there are conditions when dobutamine is first line. Whenever we consider that the baby is having birth asphyxia or that there is myocardial dysfunction, then we use dobutamine as the first line of drug. But for all pragmatic reasons, the dopamine is considered as a very common first line agent, right? So dobutamine similarly, the only difference is 1 ml contains 50 milligram. If the baby does not respond to dopamine and dobutamine, then we consider hydrocortisone. So hydrocortisone is given when the baby does not respond to maximal doses of dopamine, dobutamine, which is 20 microgram of both. So we usually give 1 mg per kg 8 hourly, and then depending upon the response, it can be given up to 2 to 3 days, right? So another vasopressor ADR can also be given after this if required, right? So if the baby is still unresponsive, we also have to look for alternative causes or the compounding factors, which could be hypoglycemia, which could be hypoxia, which could be hypothermia, which could be hyperkalemia or anemia, and the baby might be having severe sepsis, pneumothorax, or cardiac tamponade. So these all things should be simultaneously looked for and must be treated. If these things are not treated, then our baby will not get the adequate response. And we have to keep a high threshold of HB if we are treating the shock. Usually PCV of 35 is kept as per FBNC guidelines. And if you do not have the facilities for adequate stabilization of the baby at your level, after the stabilization of the baby, we might also consider referring the baby to another unit, right? So this is important. So what are the endpoints? As I've already told, normalizing heart rate or decreasing heart rate, but the bilkul terminal endpoint is normal heart rate. The baseline heart rate which the baby had, we have, should try to achieve that. Capillary refill time, which is less than 3 seconds. The pulses should be normal. The extremities should be warm to touch. The blood pressure should be normalized. Urine output should be more than 1 ml per kg per hour. So these are the therapeutic endpoints which we should try, right? So weaning, जो सबसे बाद में माइनोट्रोप ऐड करते हैं वो सबसे पहले हटाते हैं. हाइड्रोकोट सबसे बाद में किया, सबसे पहले हटाएंगे, right? So once the hypotension improves, and in addition to that, the tissue perfusion improves. So both things are important. The tissue perfusion improves as well as the hypotension improves. Then the inotrope should be tapered slowly. So 5 microgram per kg per minute we can try to decrease, but we can also go more slowly depending upon the response of the baby. If the baby has taken a long time to stabilize, suppose the baby has taken around 12 hours to stabilize, then we should not hurry. Then we should decrease inotrope in next 6 hours. So we can go very slowly. If we are going by infusion pump and we were giving 1 ml per minute of the rate, we can simply decrease by 0.9. So 2 also we can decrease. It is not mandatory to decrease by 5. So with the advent of infusion pumps, even by the decrement of 2 every 4 to 6 hourly can be done, right? So if the BP is more than 90th centile, at any point of time, the inotropes are to be tapered. Our aim is to keep the BP at 50th centile, right? If the baby is maintaining blood pressure at 50th centile and all other parameters are normalizing, we should consider decreasing inotropes as early as possible after giving adequate time for the response, right? So first hydrocot, then if the whichever inotrope was added in the end, that should be decreased, right? So inotropes are very tricky situation, and with the usage of the functional echocardiography. So with the echocardiography machine, which is now commonly present in most of the units, I must tell you now that it is not only the eyeballing which is important. We commonly have a toy at our hand, right? And we have an echo machine. So everybody thinks echo machine है, echo करके देख लेते हैं, and we see the contractility of the heart, and we consider ourselves as yes, हमने बहुत बड़ा काम कर लिया, right? So echo machine with only the eyeballing, that the contractility of the heart is not the very good parameter. We should be able to see the baby going to shock using the clinical parameters, heart rate, CRT, mottling of the skin, pulses, urine output. In addition to that, if we are using the echocardiography, we should always see the IVC, whether the baby requires more fluid, one. Second, we should do the eyeballing, that is the contractility of the heart. The third thing, we should see the systolic dysfunction. The fourth thing we should see is the diastolic dysfunction. And the fifth and the additional thing which we can see is that what is the likely cause why the baby is in shock. The baby is having PDA, structural heart disease, or some other pulmonary arterial hypertension, PPHN. That also we can see during the echocardiography. And based upon that, there are various algorithms which help us decide the higher inotrope, like when to give dopamine, when to give dobutamine, when to give ADR, vilrenone, vasopressin. But these all things are now, as of now, not in the scope of this FBNC training. But if these things are there, then you should definitely consult your seniors who are on duty and your faculty members, and they will definitely guide you regarding the choice of inotrope. But having said that, with these things, with FBNC, fluid bolus first, fluid bolus second, start with dopamine, increase up to 20, and then dobutamine is as per the FBNC guidelines and followed by hydrocortisone, right? So this is the standard chart which we should all use. We should see temperature, heart rate, respiratory rate, saturation, CRT, mean blood pressure, urine output, Downey score, and all of the things. This is routinely used in all our monitoring sheets. These things should be seen. So coming to last slide, we should all monitor all the neonates for early signs of shock, right? So early signs of shocks are very important. So that is the importance of monitoring sheet. So all good SNCUs, they absolutely focus on the monitoring sheet. So in the morning, when we see the monitoring sheet, we should always see at the end of the sheet what is the trend of the heart rate. If the heart rate is increasing, you should be suspicious. Why the heart rate has increased? If the hypothermia is setting in, why the temperature is decreasing? If the CRT is decreasing, if it is deteriorating, why it is increasing, right? So we have to see the monitoring sheet and it has to be filled diligently. Definitely a lot of time should go in filling the monitoring sheet. Second, if the shock has developed, we have to start treatment immediately. We can't wait. We can't wait. If 1 hour has gone, I mean, we have missed the bus. Not only that, the supportive care, the fluid resuscitation, as well as the inotropes are mainstay of treatment, and the baby has to be monitored on the basis of that, right? So these are the things that we should keep in mind while dealing a baby with shock. So that was just a brief about the neonatal shock. So you have been given the resources for reading about this thing only. So this PPT, somebody told to share the PowerPoint. So I must say everything has been taken from the resource which has been shared in the group. So if you go through that 6 or 7 pages, you will be able to get all of these things and then that page, right? So I'll stop sharing my screen now. So please, you can ask any question if you want. So if you have any question, you can put in the chat box also. So this this slide, these all are from that manual only, right? So anyone, any question? So one question is how rapidly we should taper inotropes, right? Okay, so very good question. So there are two important things. The first thing is we should be able to know why we started inotrope. Once we know why we started, the answer is not shock. कि shock था इसलिए inotrope start की, वो नहीं. So what is the reason of starting inotrope? Was it sepsis? Was it heart disease? Was it hypothermia? Was it something else? So once that reason is gone, that means underlying cause has been treated, then the baby is unlikely to get the same thing again. So that is the first decision that we have to see. Once that underlying pathology is removed or is stabilized, and the baby is stable for minimum of 24 hours, then we should start thinking of tapering inotropes. And then again, the last inotrope which we added, that should be removed, the first one, right? So next question is when to give ADR in units. So for all practical purpose, so we should give and think of ADR once the baby is not responding to dopamine and dobutamine, and the baby is also not responding to hydrocodone for as per FBNC, right? So very soon new guidelines will come, which might tell us. As of now, there is no evidence that which inotrope is the best to whether ADR should be given as first line, but this evidence is building up. So very soon we'll have new guidelines if that comes. As of now, ADR is to be given once the baby is not responding to dopamine, dobutamine, and hydrocodone. This is just as per FBNC guidelines, right? Okay. Anything else you want to ask? Okay, then I'll ask you two questions. So what is the first sign of shock? When do we think that the baby has started developing shock? First sign. Very good. Excellent. So it is the increasing heart rate from the baseline, right? Increasing heart rate from the baseline. Whenever the baby has got more than 20 or 30 heart rate increase after ruling out hyperthermia. So when hyperthermia is one thing which we should always look for. What is the temperature of the baby? So if the baby is not hyperthermic and the baby is having tachycardia, think of shock. And what other things we should clinically think other than heart rate, and we should see elicit in addition to heart rate. Okay. So CFT, very good. Pulses, very good. Yes. So we should see capillary refill time, pulses, pulse volume also. Okay. So the second important thing is capillary refill time. One very important thing which is also helpful in management of shock is, so if we diligently follow the monitoring sheet, you can see that the baby was having a monitoring for urine output also. If there is a gradual decrease in urine output over previous days, that is also an indicator of decreased GFR. So we can also see clinically urine output also, right? So kindly explain the mottled skin and scleroderma. Okay. So I don't know your name. This is E. Okay, fine. So mottled skin means whenever the perfusion of the baby is poor. So we all know that is a diving reflex. So diving reflex is that whenever we have got poor perfusion in the body, our body tries that the blood flow goes to the very vital organs. And unfortunately, skin is not a vital organ as far as our body is concerned. So जैसे ही हमारी बॉडी का परफ्यूजन कम होगा, the blunt has to be faced by skin. Therefore, the skin जो हमारी body की है, that will get less perfusion. And once the perfusion is less, there will be autonomic changes in the skin. So our body will have a mottled appearance, right? So that is the mottling of the skin. The second is scleroderma. So scleroderma is the woody hard feeling of the skin. So whenever there is a severe sepsis, the scleroderma is a dermal manifestation of severe sepsis in neonates. So if you have felt the wood, बिल्कुल लकड़ी की तरह बच्चा हो जाएगा. So normally, let's say we are able to pinch the skin. So whenever we want, we can pinch the skin. If we are not able to pinch the skin, the baby has got a woody hard feeling. And once you have seen scleroderma, I must tell you that आप फिर भूलोगे नहीं, लकड़ी की तरह हो जाता है बच्चा बिल्कुल, right? And let's hope आपको कभी देखने को ना मिले ऐसा ही, because once scleroderma sets in, there are very bad prognostic indicators, right? So okay, so whenever we want to do echocardiography for the baby, we should always see inferior vena cava. We keep the probe at liver and we see for fullness of IVC. If IVC is collapsible, that means there is scope of fluid. If IVC is full and with respiration it does not collapse, that means the baby does not require fluid. This is a very common indicator. So if you want to see echocardiography, so even before the contractility of the heart, see IVC. IVC देखनी बहुत आसान है. Liver की side में subcostal region पे you keep the probe, you will be able to see the collapsibility, right? Okay. Next is how do you calculate dopamine? You can unmute and tell also, right? So 28.8 milligram per kg in, if we want to give 20 microgram per kg per minute. So whatever it is, we just add this to 24 ml to make a total of 24. If the baby needs fluid restriction, then we can even increase it to double dose and then we can give 0.5 ml, right? So Neha is asking all scleroderma managed by DVAT. So whenever there is a serious sepsis, the DVT is one of the modalities by which we can decrease the mortality. So some studies have shown that if there is severe sepsis, there is some benefit of DVT. And yes, if scleroderma is there, some studies have told that, some studies have reported that scleroderma decreases, but it's not a dictum. So DVT will decrease sepsis. Once the sepsis starts improving, the scleroderma will automatically start improving. So is it possible that the baby is in shock without? It is very unlikely. Because if we remember the physiology, so whenever we have decreased cardiac output, what is the first compensatory mechanism? The first compensatory mechanism is increase in heart rate. Right? You remember cardiac output into heart rate. Right? Cardiac output is equal to heart rate into peripheral resistance. So first compensatory mechanism is increase in heart rate whenever there is a perfusion. So most of the time it is sort of certain that heart rate will increase. That's why I told we have to see increase in heart rate. Suppose there are babies of birth asphyxia. Their baseline heart rate is 90 sometimes, 102, 103, 104, 110. So in these babies, we just get an increase up to 120. And for the novice, 120 heart rate will not be more. You will think it is normal heart rate. So it is increase in heart rate, and it might not be tachycardia, right? So increase in heart rate is more important. Okay. Any other question you want to ask? Because if you ask the doubts, you'll be more versed with the technique. And any doubt you can ask. Anything. Okay, later on also, then if there are no doubts, I think it's already 20 minutes past the standard time. You can later on ask your queries in the chat box also, right? So Rashmi is asking, do we have to reduce the antibiotic dilution while calculating this? Yes, obviously. I'll give you an example. Suppose you are giving vancomycin to a baby whose weight is 1 kg, and you are giving it in the, let's say, hypothetically in 3 divided dose. So you are giving vancomycin in 10 ml every time you are giving. So if you will give 10 ml every time, the total will be 30 ml. So for a baby who is only 1 kg and our fluid is, let's say, 80 ml per kg, right? Just hypothetical. So out of 80 ml of fluid which is required, we are giving 30 ml as antibiotic, and there might be other antibiotics as well. So yes, whatever fluid we are giving in the antibiotic has to be deducted. Very good question, right? So it has to be decreased. So any other thing? Okay, then I hope some concepts of this would be clear to this. And another question is, should we minus bolus? Okay, so usually bolus is given when we think that the baby is in fluid deficit. When the baby is in fluid deficit, right? So usually bolus is not deducted because baby का कम है ना, fluid कम है इसलिए bolus दे रहे हैं. So उसका requirement we need to complete. So fluid bolus is usually not deducted. But if it is bolus of dextrose given for hypoglycemia, then it has to be deducted. So I hope you are asking normal saline bolus. So normal saline bolus is not deducted, but bolus for hypoglycemia is deducted. Okay. Our aim is to give adequate amount of fluid volume. Okay then. So with this, I think we can leave now. So thank you everyone. So if you have any kind of question, you can ask in the chat box also in the main page. We will be ready to help you in whatever query you have. So happy managing shock as well as IV fluid. So thank you so much. Rohit, should we stop this?
No, sir.
Any
Thank you, sir.
concluding-
Thank you, sir, for
any
this
concluding
wonderful
remarks?
session. I think you have everything I think has been discussed. So if somebody has some doubts, so we can discuss in chat box as it's already 9:25. So I think,
Yeah.
sir, everything is covered in this session. So probably everyone is benefited with this.
Okay. Thank you. Thank you all. Ritu,
Thank you,
you
everyone.
can end the meeting now.
Thank you, sir.
Thank you.
Thank you, everyone. Good night.
Thank you, everyone.